absolutely does seem to go away for a lot of them. And so we just tell them, ignore it. Don't expect it to be there first. And they'll say, it sucks because I'm full. I don't want to be full in the first place. Now I'm full all the time. Like, we know, you just got to kind of get, we got to, again, part of it is, you got to trust us, you got to get through this. It's going to suck for a while, and it's going to be bad. And a big part of what we do, especially first, is, it's cheerleading, right? It's getting to kind of be able to do it, and it's other people in the group telling them, like, you can, I did this, and it actually does work. It takes a couple of weeks, but you can get there. And so it's a lot of that kind of motivational piece.
Do you find, oh, sorry, I've asked people, so if you want to.
Well, I was just wondering, you started out with talking about, not having a diagnosis, just really if you're having weight problems,
right?
If you have an eating disorder,
right?
Do you see patients who are not anorexic or bulimic but are underweight due to like extreme anxiety and things like that, and then having difficulties like I'm not part of them?
Right. I have had at least a couple of people who we really think have OCD that happens to be related to food. A lot of really rigid food rules. So it's not about shape and weight exactly the same way. It's not a strive for thinness. It's certain foods feel weird. I can only eat a certain amount, or this food can't go with that food. And they get these really sort of, food rules. And one of them we treated in our eating disorder group and just said some of this stuff will be less applicable, but you've still got to eat. So she would come in and do the exposure meals, but it was for different reasons. She wasn't so concerned she was going to gain weight. She's concerned that the food's touched, or that, that she can only eat a certain kind of thing, or only this one brand of food is safe. And so it's almost like, and we do exposure with OCD also. So it was basically, we just adjusted it a little bit. The other ones I've seen independent, like individually, not as part of our group, but we basically had to do stuff on their food rules. And like we would with OCD in general, and help them break those food rules. But I think of almost like, a person who can't have, other things in their life, and there's rigid ideas that we see around OCD.
And you talked a little bit about the, I think you were mentioning the sympathetic and the parasympathetic systems. And do you see people who sometimes just really physically can't eat, like they just really can't eat?
Yeah, well, I've seen this actually with a couple of adolescent boys, elementary school age kids who have a lot of fears of vomiting, and they get so right, or they get so afraid that it makes them vomit. Right. So it's a sort of weird, paradox. It's sort of like, feeling like with panic attacks, right? You get so freaked out by your own physical symptoms that you have a panic attack. So not wanting to have a panic attack drives a panic attack. And for them, we'll do, again, some fairly, we have to tweak the exposure a little bit, but we do a lot of that kind of work with them. We have had people just absolutely paralyzed with fear about eating a specific food. Like, I can't do it, I just can't, pizza, I just can't. They're early on in treatment and they just, I just can't. So we'll have them be close, like eat a piece of it or whatever, and we'll kind of work our way there, So we'll do a lot of kind of very graduated kinds of exposures if we have to, If you can't do that in your first week, well, that's understandable. Like, so, do what you can, and then next time we'll have to do a little bit more. So we can kind of work with the people who are just too, absolutely freaked out to be able to do it, and that does happen. We used to get it in that cafeteria when I was on my internship, because again, it's 30 feet of like nothing but fat. And they would stand there and they'd be frozen. And the only other people there were all the early bird retirees who were angry. They were like, because this poor like teenager frozen in the line going, I can't even get rice, And there are these old people going, hurry up, and so we would have to just get a little bit of that and just move on, You don't have to get a dessert today or anything, just start easy. So we'll do that a lot, we'll work them into whatever they need to get to, symptom-wise and exposure-wise.
Do you find that, so like differences between age of onset, like adult onset versus like childhood onset, affects how recovery occurs, how fast it is, how ingrained those core schemas are? I think that if you get it early enough, I think you never really develop some of those coping responses. So it's harder because, a lot of people will get them and then you get the eating stuff and they kind of atrophy, but they were still there, you learned it. And sometimes if you get it at an early enough age, you just never learn coping stuff, the ways. But I think the real factor is time from onset to treatment is really the key factor. Anything less than a couple of years is actually pretty early because it's so secretive that, I had one patient ever whose mom caught her, she swore the 4th time she ever purged. Like it was within a couple of weeks, she had just started doing it, we got it, but that's really the exception. Most of the time, because people are pretty secretive about it, it isn't until they lose a lot of weight or until something catches on or something happens or they just notice, hey, you're never coming to dinner anymore. And
It can be 2, 5, 10 years. We do have, we have people who are women in their 40s and in one case in their 50s, who've had it for most of their adult life. One sort of eating disorder or another. And it's pretty well established at this point. I mean, it's, we still do the same kind of treatment. But if it is what you've done for, again, most of your adult life, I mean, some of these women have had eating disorders longer than some of the other patients have been alive. And, again, it's nice to have them there because I go, don't be me. Like, they're all pretty good about saying, like, I wish I, had been where you are now because I don't want to have to, it's really hard for me, Sometimes they'll come in, particularly if they're older, they're coming because they don't want their kids to know, or they're, a lot of cases they'll have a daughter and don't want her to end up, learning the lessons that they've gotten. So I think that's the main factor. I do think there's some particular risk factors getting really younger, just because you don't get some of those things, but really the best bet is getting in and getting treatment as soon as we find out about it. I think has a better shot. I don't have any hard numbers on that. That's my guess. I could be completely wrong and lying. But I think that's the way we think about it is that the more established something is, the harder it is to kind of re-entrench or to unentrench it and come up with something else.
Any other questions? Well, thank you so much
Sure.
for coming in.
Thanks.